Hello, everyone. Welcome to another episode of The Heart of the Matters. My name is Ramatoulie Darboe, a research fellow DMC Cardiovascular Research Unit and incoming PGY1 at ProMedicare. Today we'll be discussing an important and yet evolving topic in cardiovascular medicine, which is arrhythmia burden in cardiac amyloidosis and the role of implantable loop recorders. I'm excited to be discussing on this topic alongside some wonderful doctors, and I will allow them to introduce themselves.
I'm Dr. Peter Kamash. I am a resident at the Detroit Medical Center.
I'm Dr. Ali Awad. I'm Chief Resident at Detroit Medical Center.
I'm Dr. Khaled Elnaggar. I'm currently Chief Resident at DMC here in Valley.
All right. Thank you so much for that introduction. All right, now to the topic. Imagine having two patients at your clinic with cardiac amyloidosis, both having similar symptoms, both having comparable imaging findings, yet one developed recurrent atrial fibrillation, conduction disease, and potential life-threatening ventricular arrhythmia, while the other one remained relatively rhythm stable. Why does this happen? Can we predict it? Cardiac amyloidosis has evolved from being considered as a rare and often overlooked disease to becoming one of the most important causes of heart failure that cardiologists encounter today, whether caused by light chain amyloidosis or transthyretin amyloidosis. The hallmark of the disease is progressive deposition of misfolded protein fibers within the myocardium. And as this amyloid infiltrates the myocardium, it causes or disrupts conduction pathways, alters atrial and ventricular substrate, thereby producing that conducive environment for arrhythmias to occur, making atrial fibrillation common, conduction disease frequent, and ventricular arrhythmia a major concern. But despite recognizing this complication for years, we still have limited knowledge rather when it comes to the true burden of cardiac amyloidosis or true burden of arrhythmia in cardiac amyloidosis. And one of the reasons is because traditional monitoring method just gives us a snapshot rather. Holter monitor may capture 24 or 48 hours. Event monitor may extend this to some level. But we all know that arrhythmias are intermittent, silent, and unpredictable. And this is where implantable loop recorders comes into the conversation, and they are very much important because they provide long-term continuous rhythm surveillance. And this long-term continuous rhythm surveillance allow us to move beyond assumption and quantify exactly how often arrhythmias are going to occur, what types are going to occur, and which patients are most at risk. And therefore, the study we'll discuss today set out to do exactly that. The investigators sought to characterize arrhythmias burden in greater detail, explore the relationship between amyloid subtype, amyloid burden, and arrhythmic risks. So let's explore what continuous rhythm monitoring reveals about one of the most electrically complex diseases in modern cardiology.
Thank you, Dr. Darboe. And I would like to talk about the methods in this paper. So the EXCALIBUR study is a prospective single-center observational study that was performed at the National Amyloidosis Center in the United Kingdom. With that said, in terms of the study population, treatment-naive patients were recruited that were recently diagnosed with either transthyretin amyloid cardiomyopathy or light chain cardiac amyloidosis. In terms of the total amount of patients, 110 total were recruited, 63 being in the transthyretin group and 47 being in the light chain group. Of note, the transthyretin group was further divided into two other subcategories, a wild type group and a variable group. Of the 63 transthyretin group, 43 were considered wild type and 20 were considered variable. These patients were all consented for an implantable loop recorder from May 2021 to June 2022. The loop recorders were programmed to automatically record if the heart rate dropped under 50, if the heart rate went over 110, or if it detected a pause of 3 seconds or more. All the patients were followed for a minimum of 18 months or until a terminal event occurred or unless a cardiac device was implanted. The diagnosis of amyloidosis was made through the established diagnostic criteria. All patients also had confirmation of cardiac amyloidosis as well. And this confirmation was made through the utilization of transthoracic echocardiograms and cardiac MRI. In terms of cardiac MRI, it was mainly used to calculate the extracellular volume fraction, which in turn was utilized to determine the amyloid burden of each patient. An extracellular volume fraction of 50% or more was selected to represent a moderate or severe amyloid burden, which is consistent with the current literature at hand. In terms of statistical analysis, the study analyzed a time to event outcomes through Cox proportional hazards regression. Of note, the decision was made to analyze both the transthyretin group and the light chain group separately due to their biological and clinical differences. And with that said, I would like to transition to Dr. Awad to discuss the results.
Thank you, Dr. Kamash, for discussing the methods. So, regarding the results section, as you mentioned, this study enrolled 110 patients with cardiac amyloidosis. 63 had ATTR cardiac amyloidosis, and 43 were wild type, and 20 were variant, and 47 had the light chain cardiac amyloidosis. So, the mean age was 70 years, and 80% were male, with 20% female. Critically, all patients receive an implantable loop recorder enabling continuous rhythm monitoring from that point of diagnosis. That's what you mentioned in your section, Dr. Kamash. So for the baseline phenotype, at baseline, the ATTR cardiac amyloidosis cohort demonstrated more advanced cardiac involvement. These patients were older, more frequently male, and higher prevalence of atrial fibrillation and conduction disease on the resting 12 EKG, 12 lead EKG, sorry. They also exhibited greater wall thickness, higher LV mass, and larger biatrial dimensions, together with higher amyloid burden. This was very reflected by a greater proportion of transmural late gadolinium enhancement and consequently a higher ACV fraction that you mentioned in your method section too. So within the ATTR cardiac amyloidosis group, the wild type carried the most advanced phenotype relative to the variant subtype. So over a median of follow-up of 36 months, clinically significant bradyarrhythmia defined as class 1 guidelines indication for pacing occurred in 19 patients or 17.3 of the cohort. The distribution was markedly subtype dependent. So 30.2 in wild type ATTR, 10.0% in variant ATTR, and 8.5 in light chain cardiac amyloidosis. So the overall incidence was 8.0 per 100 person years, rising to 11.1.2, in ATTR cardiac amyloidosis versus 3.8 in light chain cardiac amyloidosis. The predominant mechanism was the high degree AV block, including 8 cases of complete degree AV block and 5 cases of Mobitz type 2 block, with the remainder comprising tachybrady syndrome and symptomatic junctional bradycardia. So, regarding the atrial fibrillation, among patient in sinus rhythm, without a prior history of atrial fibrillation, 28.2% developed new onset atrial fibrillation during follow up at overall incidence of 12.4 per 100 person years. New onset AFib was more common in ATTR, occurring at 28.9 per 100 person years compared with 4.6 in light chain amyloidosis. All patients with atrial fibrillation were initiated on oral anticoag for thromboprophylaxis. However, no ischemic stroke happened during that period. So, for the ventricular arrhythmia, the pattern inverts, which is sustained ventricular arrhythmia occurred exclusively in light chain. It's 9 ATTR, it's in light chain. These were 3 patients at a rate of 2.7 per 100 person years, comprising both monomorphic and polymorphic ventricular tachycardia. No patients with ATTR cardiac amyloidosis experienced sustained ventricular arrhythmia. However, non-sustained ventricular arrhythmia was detected in 12 patients overall, distributed across all subtypes, and was uniformly asymptomatic. So, In this paper, the predictors and substrate were done on regression analysis. So the arrhythmic burden tracked with disease biology with higher ECV, which our marker of amyloid infiltration in the study was associated with clinically significant bradyarrhythmia, new onset AFib, and also advanced conduction disease, which is the AV block. PR interval prolongation, QRS widening on the baseline ECG likewise predicted subsequent development of the bradyarrhythmia requiring the device. This supports a shared substrate of progressive conduction system infiltration with the lower amyloid burden invariant ATTR accounting for its lower arrhythmic expression. So in summary, the type of the arrhythmia is subtype specific. ATTR and wild type in particular is dominated in bradyarrhythmia and conduction requiring the device. However, the AL cardiac amyloidosis carries the sustained ventricular arrhythmia risk across both the arrhythmia burden scales with amyloid infiltration as quantified by ECV fraction, as Dr. Kamash mentioned before. I'm done with my section. I transition the mic to Dr. Nagar.
Thank you, Dr. Awad. So the study provides, a very detailed perspective evaluation of arrhythmia burden in cardiac amyloidosis, and it really offers several findings that influence at least how I think about rhythm surveillance and the sudden death risk in amyloidosis. One of the first things that Dr. Awad mentioned that really opened my mind was, clinically significant arrhythmias in amyloidosis like appear much more common than I previously appreciated. Previous literature really relied heavily on, retrospective cohorts, intermittent EKGs, device interrogations, or, clinically symptomatic triggered monitoring. But by continuously monitoring like loop recorders, the study demonstrated that arrhythmias, were entirely asymptomatic and would likely have remained undetected in routine practice. Secondly, the pattern of the arrhythmias were highly dependent on the amyloid subtype. Patients with transthyretin cardiac amyloidosis, particularly the wild type, they experienced the greatest burden of clinically significant bradyarrhythmias and new onset AFib. And, it was crazy to me that, 1 in 6 patients ultimately developed like a class 1 indication for pacing, like Dr. Awad mentioned. And half of the transthyretin patients without prior AFib develop new onset AFib. So this supports this concept that transthyretin cardiac amyloidosis, behaves as this progressive infiltrative conduction disorder rather than this like restrictive cardiomyopathy that we were taught in med school. So another thing that was really interesting was, the strong relationship between amyloid burden and, electrical disease. The higher extracellular volume on a cardiac MRI was associated with greater risk of conduction abnormalities, significant bradyarrhythmias, and AFib. And so it suggests that, as amyloid, increases and infiltrates and remodels the heart, it makes the electrical signals travel more slowly and less reliably. And so basically, the more the amyloid accumulates, the greater the chance for the heart to develop arrhythmias, which sort of makes sense. And so, imaging markers with extracellular volume is just capturing that underlying structural change in the heart, which is driving the arrhythmia. And so we could, start to think about using imaging in the future to sort of, risk stratify these arrhythmias and, try to time the, rhythm monitoring in the future. Additionally, the findings regarding like ventricular arrhythmias are perhaps some of like the most provocative. Sustained ventricular arrhythmias were uncommon and, really only occurred in patients with light chain cardiac amyloidosis. And, the terminal rhythm in nearly all the deaths was PEA rather than, having VTAC or VFib, which challenges, the previous traditional assumption that sudden cardiac death and amyloidosis is more ventricular driven. And that can also sort of explain why ICD therapy was, is showing like inconsistent benefits in prior observational studies in patients with cardiac amyloidosis. So clinically, this study raises the question of whether, our current management studies are focused on the right targets. So rather than, really focusing on emphasizing ventricular arrhythmia prevention alone, we might have more value in just early recognition of conduction disease, closer rhythm surveillance for AFib, and identifying patients, who might benefit from just earlier pacing strategies. At the same time, the study did have several limitations that we do have to consider. It was just a single center study. There was a limited sample size, only 110 patients. There was a limited number of ventricular arrhythmia events. There was lots of restriction on, just generalized interference and, variable adjustment. Also, just in terms of treatment effects, they weren't fully separated. So some patients who were receiving disease modifying therapy after enrollment, we're still present in the study, so we do have to consider that, with all the results. Ultimately, though, the EXCALIBUR study, really shifts the conversation around cardiac amyloidosis from, how often do these ventricular arrhythmias really occur towards this more broad question of, how does progressive amyloid infiltration affect, the electrical substrate of the heart? And the answer from this study, at least for me, was that progressive conduction disease might be, the main defining feature of the clinical course of cardiac amyloidosis a lot more than we thought. So, do any of you guys have any more thoughts or input that you want to bring in?
I think one of the most important thing about the study is that for me personally, it doesn't really deepen my understanding of the disease, but also raise important questions about risk stratification and monitoring strategies, and ultimately how we care for patients with cardiac amyloidosis. And I think that's important.
I definitely agree with you.
Be curious to see as you treat cardiac amyloidosis with treatment modalities to see how that changes the incidence rate in the arrhythmias. Maybe a future study.
For sure, for sure.
Yeah, and also I think sensitivity analysis would be important in the case of ventricular arrhythmia. Like just to differentiate, is it like monomorphic or polymorphic? But we all know that the sample size is very low, so that's hard to do in this study, maybe for prospective studies.
It would definitely be more interesting to see, larger sample sizes and how that would affect our sensitivities.
Exactly.
That makes sense.
All right. Thanks for everyone for watching, and we hope to see you again pretty soon.
Thank you.
Thank you very much.